There are pregnant mothers who enter the final weeks of pregnancy believing everything is still completely normal. The baby is still moving every day. No contractions, no bleeding, no pain strong enough to make them think danger is already close. They are still walking normally, folding baby clothes, preparing the hospital bag, assuming that when labour truly begins, the body will naturally know what to do. Then a routine ultrasound ends with one short sentence. The placenta is covering the cervix. The baby is lying sideways. This pregnancy may no longer be safe for vaginal birth. What breaks many mothers emotionally is not always the diagnosis itself. It is the feeling that nothing inside the body seemed wrong beforehand. No dramatic symptom, no obvious warning, no sensation powerful enough to signal that the situation had already crossed into danger. And that silence becomes psychologically dangerous. Because many people unconsciously believe real danger should feel obvious, that if something serious were happening, the body would somehow announce it loudly. Severe pain, heavy bleeding, violent contractions, something undeniable. But real obstetrics often works very differently. There are pregnancies where the risk already exists deep inside the structure of the system long before the mother can physically feel anything at all. And by the time visible symptoms finally appear on the outside, the amount of safe time left to regain control may already be frighteningly small. Many people think a C-section only happens after labour has failed, after hours of unbearable pain, after exhaustion, after an emergency suddenly explodes in front of everyone. But some obstetric decisions are not made because labour has failed. They are made because the internal system itself no longer contains the conditions required for safe labour to happen from the beginning. Because labour does not begin with sensation, it begins with structure. Inside the uterus, contractions generate force downward toward the cervix. But that force cannot work alone. It must travel through a stable mechanical pathway. The baby's head normally functions like the central pressure transmitting point that allows force to move downward in a controlled direction. Hormones soften tissue, the cervix gradually thins and opens. Muscles coordinate rhythmically, blood flow adapts continuously. Anatomy, timing, tissue flexibility, fetal position, and pressure mechanics all have to remain aligned simultaneously. When that system stays aligned, labour can progress naturally. But when even one critical part no longer fits safely into the system, the danger may already exist before pain even begins. And that is why some pregnancies can still appear completely normal on the outside, while obstetricians already know the pathway to safe vaginal birth is disappearing internally. So one of the clearest examples is complete placenta previa. Many mothers with placenta previa still feel perfectly fine, so the baby moves normally, daily life continues normally, but the placenta is no longer attached safely high inside the uterus. It now covers the cervix itself, the exact exit pathway the baby would need during delivery. And this changes everything, because once the cervix begins opening, the placenta's blood vessels are stretched and pulled apart along with it. Unlike cervical tissue, blood vessels cannot safely expand during labour. They can tear extremely fast, which means the true danger does not begin only when visible bleeding suddenly appears. And the danger begins the moment the cervix starts changing internally. That is why doctors often do not wait and see with complete placenta previa. And the question is no longer whether the mother is strong enough to attempt labour. The question is whether a safe pathway for labour still physically exists. And in many cases it does not. Another condition many pregnant mothers have never heard of is vasa previa, where exposed fetal blood vessels run directly across the cervix instead of remaining protected safely inside the placenta or umbilical cord. Everything may still seem calm until the membranes rupture. Then within seconds those vessels can tear. The terrifying part is that the blood being lost is not the mother's blood, it is the baby's. A fetus only contains a very small total blood volume, sometimes only a few hundred millilitres in the entire body, which means blood loss that might appear survivable for an adult can become catastrophic for a fetus within minutes. Oxygen delivery drops rapidly, the fetal heart rate collapses, brain injury may begin before the family even understands what is happening. And this is why obstetrics often focuses on preventing the dangerous phase entirely instead of waiting for catastrophe to visibly unfold first. Some of the most dangerous pregnancies are dangerous not because labour has started, but because labour itself may trigger the disaster. Placenta accreta spectrum disorders are another example. Normally after birth, the placenta separates naturally from the uterine wall, while the uterus contracts to control bleeding. But with placenta accreta, the placenta has invaded too deeply into the uterine muscle itself, which means the body is preparing to perform a process the uterus may no longer safely allow. Many people think the danger exists mainly during pregnancy, but in reality some of the greatest danger appears in the minutes immediately after delivery, once doctors attempt to separate an abnormally invasive placenta. Large blood vessels can tear open simultaneously. Massive hemorrhage can happen terrifyingly fast. Not as a slow trickle, not gradually. Entire blood volume can begin disappearing before the outside situation even fully reveals itself. And that is why some deliveries require blood products prepared beforehand, surgical teams already assembled beforehand, and sometimes even preparation for hysterectomy before labour ever begins. Not because doctors prefer surgery, but because waiting until the bleeding fully explodes may leave almost no safe time left to regain control. The same principle appears with high-risk uterine scars. Many mothers believe that if pain is still tolerable, then the uterus must still be safe. But scar tissue does not have the same elasticity or structural strength as normal uterine muscle. As contractions intensify, pressure concentrates across the weakest area of the uterine wall. And uterine rupture does not always begin with dramatic screaming pain. Sometimes the first sign is fetal heart rate collapse, sudden instability, labour abruptly stopping, internal bleeding beginning silently before the outside situation fully reveals itself. There are pregnancies where everything still appears stable minutes earlier, yet minutes later oxygen delivery to the fetus is already critically compromised. This is why obstetrics sometimes intervenes before labour reaches maximum stress. Not because the body has already failed, but because doctors understand what the structure itself may no longer survive safely. And the same idea applies when fetal position destroys the mechanics of birth itself. And when a baby lies transverse, the uterus may still contract powerfully, but the pressure no longer has a stable downward axis through which it can safely move. In brow presentation or certain face presentations, the baby's head enters the pelvis at an unfavourable angle, increasing the diameter, attempting to pass through the birth canal. And this is where many people misunderstand labour. Not every difficult birth is solved by trying harder. Sometimes the limitation is mechanical. The uterus can contract normally for hours while the baby still cannot descend because anatomy itself no longer permits safe passage. The stronger contractions become, the more stress accumulates inside a system that was already mechanically misaligned from the beginning. This is also why severe cephalopelvic disproportion becomes dangerous. Yes, many large babies are delivered vaginally. The fetal skull can adapt somewhat. Every pelvis is different. But once the mismatch crosses a critical threshold, effort alone cannot overcome physics. The body cannot force a safe passage through a pathway that no longer fits safely. And the longer labour continues under those conditions, the greater the risk of fetal distress, infection, maternal exhaustion, hemorrhage or uterine rupture. This is also why doctors react so aggressively to cord prolapse. Normally the baby's head seals the cervix, but if the umbilical cord slips downward first, after the membrane's rupture, every contraction may compress the cord directly, which means oxygen to the fetus is being interrupted minute by minute. This is not a situation where the body can calmly adjust itself later. Brain injury from oxygen deprivation depends heavily on time. Every passing minute matters. Twin pregnancies can create another unstable birth pathway entirely. Not all twins require C-sections, but when the first baby is not positioned head down, the entire birth axis becomes less predictable. Cord prolapse, fetal entrapment, or sudden positional instability can develop extremely fast once labour begins. Because in obstetrics, the first baby functions like the opener of the entire pathway. If the pathway itself begins unstable, the situation can deteriorate within minutes. Severe maternal conditions create another invisible form of danger altogether. In severe preeclampsia, uncontrolled hypertension, or high-risk heart disease, the problem may no longer lie mainly inside the uterus. The entire cardiovascular system may already be operating dangerously close to its limit. Each contraction changes blood pressure, heart workload, circulation and oxygen demand simultaneously. Some mothers may still appear completely calm and alert on the outside, while internally the body is already approaching circulatory collapse. And once that threshold is crossed, deterioration can happen frighteningly fast. And that is why controlling the timing of delivery is sometimes not intervening too early. It is preventing the body from entering a state where recovery may no longer be possible quickly enough. Some babies also require immediate intervention the moment they are born. Severe airway obstruction, critical heart defects, conditions where even a delay of several minutes in oxygen support or resuscitation may allow irreversible injury to begin. In these situations, the goal is not simply delivering the baby, it is delivering the baby at the right moment, in the right place, with the right team already waiting before instability begins. Even active genital herpes during labour demonstrates the same principle. The issue is not whether the mother feels strong enough to continue labour. The issue is whether the pathway itself remains safe for the baby to pass through. And this is the brutal reality many mothers struggle with emotionally. These decisions are not determined by pain tolerance, not by determination, not by how hard the mother pushes, not by whether she emotionally wanted to try harder. They are determined by anatomy, placental position, fetal alignment, blood flow, uterine integrity, mechanical limitation, oxygen stability, and whether a safe birth pathway still physically exists. And this is the part many mothers grieve the most, the feeling that they were never even given the chance to attempt vaginal birth. But in many cases, the issue is not that doctors took away the opportunity. The issue is that one of the fundamental safety conditions required for natural birth had already disappeared before labour ever began. Because not every contraction leads safely toward delivery. And by the time many obstetric catastrophes finally become obvious on the outside, the remaining window to regain control is often far shorter than most people realise.